Greetings, my name is Lindsay Ma, and I'm a rising intern in internal medicine. Today we'll be covering COPD exacerbations. Fortunately, less than 1/3 of patients with COPD are frequent exacerbators. However, because there are 16 million patients with COPD, we encounter these exacerbators quite regularly. Therefore, it's important to be confident in your ability to diagnose and manage COPD exacerbations. The target audience for this talk is clerkship level medical students, so let's see what we can learn today. Let's assume that you've already assessed their ABCs and stabilized the patient. Patients with COPD can develop exacerbations. How do we know if it is a COPD exacerbation? Well, these symptoms should develop acutely, on the order of hours to days. Furthermore, patients will have developed respiratory symptoms, including dyspnea, as well as cough and sputum. Since patients with COPD tend to have baseline levels of dyspnea with some degree of cough and sputum production, we're really wondering about changes in these and increasing frequency or severity of these symptoms. Specifically, we want to ask about dyspnea severity using the VAS scale, which is a visual analog scale that patients can look at and point to a picture that they best identify with. This scale allows us to compare the patient's symptoms at one time point to another because it's a consistent 0 to 10 scale. As for their cough, you can ask about symptom frequency. And as for sputum, you can ask about changes in the amount, the color, and whether there is new purulence or blood in the sputum. These symptoms can occur in other conditions too, though. So items on the differential we have to consider include pneumonia, pneumothorax, pulmonary embolism, pleural effusion, and arrhythmia. We also want to consider myocardial infarction as well as acute heart failure. An exam and further tests will help you differentiate between a COPD exacerbation and something else on the differential. On exam, you'll want to check their vitals. You may notice tachypnea or tachycardia, and when you start talking with them, you might notice altered mental status, as well as increased breathing effort, as well as wheezing. These are some of the exam findings you may just notice while you're talking with the patient and assessing for triggers. Those triggers can include respiratory infection, environmental irritants, as well as sudden changes in the weather. Some patients report extreme cold or extreme heat to be triggering for their COPD. Although COPD is a clinical diagnosis, tests can be helpful to distinguish between a COPD exacerbation and something else on the differential. The first test to get would be a chest x-ray. The chest x-ray may be able to rule in a pneumonia if there's consolidation, pneumothorax if there are clear areas lacking lung marking, or pleural effusion if there are signs of fluid at the bottom of the lungs. A CBC might show a leukocytosis suggestive of infection, or anemia suggestive of bleeding. A BMP can help you identify electrolyte abnormalities that might support a diagnosis of heart failure or an arrhythmia. And an EKG could help you rule out myocardial infarction. Some other tests are optional, and whether you get them should depend on the clinical picture. These include blood gases, such as an ABG or a VBG. This can demonstrate potential respiratory acidosis due to hypercarbia, and an RPAN could help you identify if there are respiratory triggers, perhaps viral ones. A CRP can be helpful to increase or decrease your suspicion of a bacterial infection. Let's say the patient has this new cough and you're trying to figure out, is this a COPD exacerbation caused by a bacteria or a virus? If the CRP is negative, bacterial infection is unlikely, and so you can avoid unnecessary antibiotics for this patient. So let's say all these tests come back negative, meaning the other items on your differential are unlikely, and COPD exacerbation is what you've diagnosed a patient with based off of their clinical picture. How do we figure out the correct treatment for this patient? Well, patients with COPD exacerbations across the board should get some inhaler nebulizer therapies, something that they can breathe in and get to their lungs. Those treatments should be at the very least a SABA or a short-acting beta agonist. An example would be albuterol. Some institutions also have access to SABA-SAMA combo medications, such as duonebs, and the SAMA stands for short-acting muscarinic antagonist. Again, all patients with any severity of COPD exacerbations should be getting inhaled therapies, at the minimum a SABA, if not a SABA plus a SAMA. Now, how do we figure out if a patient also needs some adjunctive therapies, such as antibiotics and steroids? Well, then we need to grade the patient based off of these 5 criteria. The first is dyspnea. We use that VAS score and are looking for anything greater than 5. We also look for tachypnea, tachycardia, and hypoxemia based off of their home oxygen requirement. Some patients might be on 2 liters at home or on room air, and that is the baseline we use. Lastly, we want to assess for a CRP greater than 10 if you ordered it. And so of these, if 3 or more of these 5 criteria met, then we diagnose them with moderate COPD exacerbation. If less than 2 of these criteria are met, the patient is categorized as having mild COPD exacerbation. And we can start with just inhaled therapies and monitor them for improvement. The way that I remember the difference between mild and moderate is based off of the number of syllables these phrases have. Where moderate has 3 syllables and mild has 2 syllables. And the mild diagnosis is given if you have 2 or fewer of these criteria met, where moderate is the diagnosis given if 3 or more criteria are met. So the criteria number matches the number of syllables. If the patient is diagnosed with moderate COPD exacerbation, so they get the inhaled therapy the same, but we also have to add an antibiotic. And you can also consider adding an oral steroid. Lastly, we want to talk about the severe COPD exacerbation category. Patients are diagnosed with severe COPD exacerbation if there is hypercarbia and acidosis. If both of these criteria are met, it doesn't matter how many of the 5 other criteria are met, although it's likely they have many of those met as well. As long as there's hypercarbia and acidosis, it's a severe COPD exacerbation and should be treated with the baseline inhaled therapies, antibiotics, and now we need to be talking about not if to give steroids, but what kind of steroids to give. IV will often be appropriate because severe COPD exacerbations will likely require several days of hospitalization. And in addition to this, patients might require mechanical ventilation or, at the very least, non-invasive ventilatory support. So to summarize, patients with COPD can develop exacerbations. Exacerbations look like changes in their respiratory symptoms on a very short time frame. And these can be triggered by respiratory infections most commonly, but also environmental irritants like smoke, as well as sudden changes in weather or temperature. When we assess our patients, we want to be asking about these triggers and quantifying the changes in their dyspnea, cough, and sputum. On exam, these patients will likely have tachypnea, tachycardia, and changes in their respiratory effort. They may also have mental status changes if this hypercarbia has led to acidosis. Tests will be helpful in calibrating our concern for other items on the differential. Must-get tests include chest x-ray, CBC, BNP, and EKG. And we can also consider getting blood gases, respiratory panels, and CRP. If you've diagnosed the patient with COPD exacerbation based off of their clinical picture, you'll next want to figure out if they are mild, moderate, or severe. Regardless of their severity, you'll want to start them with inhaled therapies, at the minimum a SABA such as albuterol, although duonebs are a great alternative. If they have 3 or more of these 5 criteria met, we know they have moderate COPD exacerbation and they should have antibiotics added to their regimen, with possible oral steroids added as well. Finally, If there is evidence of hypercarbia and acidosis on their blood gases, they are automatically moved into the severe COPD exacerbation category and warrant not just inhaled medications, but also antibiotics and steroids. You may want to give IV steroids instead of oral steroids at this time. And please consider whether they need non-invasive or even invasive mechanical ventilatory support. Your time is precious, so thanks again for joining me for this talk. Until next time.